Good evening, everyone. Welcome to the Deakin University Optometry Alumni webinar. It's our first webinar for the optometry alumni, and tonight we're bringing to you advanced paediatric optometry insights. Tonight we have joining us Linda Robertson, Hayley Birch, and Daniel Farrugia. I'm Amanda Edgar, your president for the Deakin Optometry Alumni Chapter, and tonight we're broadcasting to you live from the Deakin Wampons estate. But again, welcome to the Optometry Alumni webinar. Tonight we're presenting on advanced paediatric optometry insights, and our first speaker today is Linda Robinson. Linda graduated from Melbourne University with a Bachelor of Science in Optometry, followed by a Master's in Optometry. She has over 20 years of experience in the field and is currently a clinical skills lecturer at Deakin University. She also works in practice and owns her own business in addition. Thank you for joining us today, Linda. I'll hand it over to you for your presentation.
Thank you, Amanda. Okay, so the case that I'd like to present tonight is a case of a little boy who presented with accommodative esotropia and subsequent amblyopia. We first saw him when he was only 12 months old, a little dot of a thing, and his mum was very apprehensive when she came in. She had had a really bad experience when she was a little girl. She was teased a lot at school for wearing glasses, and she was really worried about the possibility that her children might need to wear glasses. And at that visit, this little fellow looked really quite good. He had moderate amount of hyperopia, which was normal for his age. His eyes did look straight, and so we scheduled just a regular review for 12 months. He didn't make it to 12 months later. About 9 months later, his mum brought him back because his parents had noticed his right eye was turning inward when he was very tired. So not all the time, just on those odd occasions when they'd noticed he was tired, the eye would wander inwards. And at that age, it's pretty difficult to measure vision, but one of the techniques, of course, that we can use is just covering the eye that we suspect is the good vision eye, and to see whether the child reacts poorly. And he didn't. He was quite happy to have his left eye covered. The ret was coming up a bit higher than it was 9 months ago. And because there was an intermittent turn, we recommended that he should perhaps wear glasses. But the mum, as we mentioned before, was really resistant due to her own experiences. So we counselled her to watch closely to see if that turn was increasing in frequency and to return promptly if they were concerned. Otherwise, due to his young age, I was quite happy to let him go for another 12 months if they were. So he came back at almost 3, but now the right eye was turning in pretty much all of the time. And we were able to get a visual acuity measurement, or a vision measurement, with single optotypes, or pictures in this case. And he was not doing too bad, 6.75 and 6.9. And initially his eyes did look straight, but when you really pushed and got him to try and pay attention, which is kind of hard sometimes with little kiddies this age, but he did try really hard, and we did notice that his right eye turned in. And it was just an interesting thing that he seemed to have poorer vision with his left eye. So I started wondering whether there was an alternating turn, and we just happened to be seeing that right eye turning today. Maybe the left eye was turning at other times. And his dry ret, we were still getting a little bit more plus in the right eye, so I figured, that pretty much matched. So this time I was a bit more strongly recommending that he would need glasses, and the mum was really still resisting treatment. So at that point I offered a referral to an ophthalmologist in order for her to have a second opinion from perhaps somebody that she thought would be a bit more trustworthy. So we referred her to a local ophthalmologist who happens to have lots of kids herself, so we knew she'd be pretty good with dealing with a little fellow. And she confirmed that there was a right convergent strabismus. Vision, she wrote back, was 6.9 in each eye. She did a cycloplegic ret, got about +5 and 450. And she made a note that she thought it was interesting that she noticed a retraction of the right globe on left gaze. I hadn't noticed that, but she wrote that that was what she'd found. So she recommended at this point to just pop him into plus 250s and for them to return to her in 3 months. But the patient didn't get those glasses made up and didn't go back to the ophthalmologist or to myself at that point. So this is what we call loss to follow-up, which is rather sad. What the mum did is she'd heard of an alternative treating optometrist that had moved into the Greater Geelong region, and his theory was to try and wean people out of needing glasses. So the glasses that he had when I saw him next were plus 050 in each eye with some micro prisms in inverted commas, so very, very tiny amounts of vertical and horizontal prisms designed to make the eyes feel more comfortable. Not surprisingly, this was not controlling the turn. So this is when I saw him next, when he was 6.5. Now the mum was really concerned. The eye seemed to be turning in the whole time. She even thought the left eye was turning in also. So she was really upset. The vision in the right eye had really dropped and there was no stereopsis. So once again, I recommended changing his glasses to the higher script and to start patching. And once again, she wanted a second opinion. I suggested she return to the original ophthalmologist, but she didn't want to do that either. She was a bit embarrassed, I believe, to go back to her. So I referred her to a very well-known strabismus surgeon and specialist in Melbourne. And the reply I got from this ophthalmologist was gorgeous. He enthused it was very good that this young fellow had bounced back into mainstream eye care and that he's diagnosed failed alternative treatment, right esotropia, a V pattern or an oblique muscle dysfunction, which was obviously what was causing that retraction of the globe on left gaze, right amblyopia, hyperopia and latent hyperopia. He prescribed +4 for each eye and patching of Atropine drops twice a week to the left eye with a review in 2 months. So even though we thought that this would be fine, it looked as if he was going to be straight with those wet ret results, he still persisted with a right esotropia even with his full correction. And so ultimately surgery was performed in 2012. The vision in the right eye proved to be very variable at different times. He would respond well to the atropine in the left eye. The vision would come up in the right eye, but then decreased again when the atropine was withdrawn. And my feeling is that if we'd got onto this a lot earlier and had some chance of him having binocular vision earlier, that there wouldn't be as much regression with patching at this age. So I saw him again, caught up again when he was a few months shy of 8. He needed just a new referral because he'd just finished a course of Atropine drops to the left eye and was heading back to see the surgeon in Melbourne. He was still having a bit of an alternating esotropia at this point, so my initial thought that there might be that alternation turned out to be true. And at this point, Mum was quite happy with his progress. He was looking straight to her in the distance with the glasses on. It continues. We're going up and down like a roller coaster with this little fellow. The vision in the right eye had dropped again to 6/12, only weak sensory fusion present, and so we commenced Atropine drops again. By 8, we're still bouncing up and down, about 200 seconds of arc, but fairly good vision. And almost 9, it's dropping down again in the right eye. So at this point, even though he looked straight at distance, we gave him a little bit more plus at near. So we gave him some progressive lenses and we recommenced Atropine drops, or we recommended recommencing Atropine drops, but patient's mum decided enough was enough. She'd had it with these drops and decided that 6/9 vision was good enough for her. So luckily, he remains about 6/9. We've kept him in the progressive lenses because he still gets a fairly decent foria without the ad. And even though, he's still only about 6/9, Mum's still declining further amblyopia therapy. I think this might be I saw him a couple more times. One time when he broke his glasses, And then another time when he came in and wanted contact lenses for football and soccer. And another time when he wanted some new glasses. So look, it goes on. These people aren't like see them, treat them, that's it. I mean, that's a whole relationship with that family that we've had with their ups and downs. So a little bit of theory. What causes unilateral amblyopia? Well, it can be anisometropia, primary strabismus, or stimulus deprivation. So in this case, it was the latent hyperopia causing the strabismus. But he also had this muscle imbalance, which ultimately required extraocular muscle surgery. So treatment of patients like this is the first step is to give their full refractive correction. So we either go for the wet ret results for hyperopes or a partial refraction, which gives them ortho at distance. The debate about whether full corrections interferes with the emmetropization process is quite strong. There are conflicting results in the literature. You might like to have a look at that reference that I've given there, to prescribe or not to prescribe. And it really sort of goes up and down as to whether or not you should give a partial correction, because that way at least you're letting the child accommodate a bit, which is the normal state for most mildly hyperopic children. So sometimes full corrections they feel can be a problem. But in this case, we had to push that full correction, otherwise we're never going to control the turn, we're never going to get anywhere with trying to keep him straight and therefore to treat the amblyopia and get some sort of binocular vision. Second step to your treatment is to review. Typically after a month. I know when I trained we sort of used the rule of thumb of 1 week per year of age, but I think these days it's the PEDIG says 1 month. And what you'll find is that there will be some improvement in amblyopia with just the refractive correction. I tend to see more when they're anisometropic rather than strabismic, and I tend to see more when they're younger, but there will be some improvement, and it's worth not starting patching straight away, but to let them wear their glasses for that first month to see what improvement you're going to have. The third step for your treatment is the occlusion therapy, and the results of the PEDIG studies are quite interesting. When they look at 2 hours occlusion, it's the same as 6 hours occlusion for moderate amblyopes, and 6 hours is the same as all-day occlusion for severe amblyopes. So we don't actually need as much occlusion as we, back once again when I trained, as we used to think we did. But you do need more occlusion for older children and for strabismic versus anisometropic patients. So keep that in mind. If you've got somebody with quite a big turn and they're older, like this child was, then they need far more time occluded or penalised, as with the Atropine, than you would if you had a 2-year-old that just had anisometropic amblyopia. Some of the PEDIG studies found that 2 hours with near work worked better than 2 hours of occlusion alone, and some found no difference. So I think the jury's still out on whether we use near work. I certainly don't think it hurts. I think that when the child's patched, if they're given something that they really like doing up close, then that might distract them a little bit and keep them a bit more interested in keeping the patch on. So I don't think it hurts to be recommending near work, but I don't think it matters if they do other things without the has the patch on without near work as well. So what about recurrence? This young fellow in my case definitely had a huge amount of recurrence. Every time he stopped the Atropine, he would start decreasing in vision again. So the statistics are it's between 13 to 24% of people will decrease by about 2 or more lines in the first year after ceasing treatment. However, there's no good evidence to support the weaning of occlusion. Even though there's no good evidence to support the weaning of occlusion, in young patients I tend to do that. I'll go from 4 hours a day to 2 hours a day to 1 hour a day while that vision is remaining stable, to 1 hour every second day to 1 hour a week, just so that they're not stopping occlusion altogether. It's when you stop occlusion altogether and they're still in that period of time where they could become amblyopic, that they may recur a little bit. So what about the critical period? So we used to think that amblyopia could only actually be treated up to about 8 years of age, and after that we should abandon trying. But 50% of children in the 7 to 17-year-old age group will benefit from occlusion therapy. So it's certainly something that you can offer patients, keeping in mind that they'll need fairly aggressive occlusion compared to if they were younger than 7. And what about atropine? I never used to use Atropine, but that was because I wasn't allowed to prescribe it when I first graduated. But now that I can, it's a wonderful second option. It certainly is something that once the drop's in, the child can't pull the patch off. And it seems to work really well for school-age children because, once again, after they're 7, you want to have more hours of occlusion, but that's really, really hard with a child that's at school all day. With this age children, once they're at school, you can pop the drops in on a Friday afternoon after school, spend most of the weekend really quite effectively atropined, and then by the time they're about midweek, they're seeing fairly normally and they get most of their school week able to cope quite nicely. It blurs the vision to around 6:30, so that's pretty rough if that's your good eye, and your amblyopic eye is also about 6:30. That can be pretty poor vision. But fortunately, it does work fairly quickly, and so it's only a few weeks before the child's noticing that it's not as difficult to cope. There is a gap in the research. We need to have a little bit more research into whether it's effective for severe amblyopia. So if the child is worse than 6:30 in their poor eye, is this blurring them enough in the good eye to actually make it work? And we also need a bit more research for that older age child. So the take-home message from this case is we know which treatments are going to work. The trick is to get the parents to actually agree to do them. And as this case illustrates, it's a long journey from the first diagnosis as a toddler to careful maintenance as a teenager. And don't be afraid to ask for second opinions, as in this case it took an optometrist and 2 ophthalmologists to convince the parents of the right course of action. And now, thank you very much. Are there any questions?
Great. So thanks so much for your insightful presentation, Linda. That was a great way to get this webinar started. And you guys out there listening, we now have the opportunity for you to ask any questions or start the discussion with Linda. So please feel free to use that question box that we had last time open for you, and we'd love to hear from you. So our first question that we have for you, Linda, today is that you mentioned there's a chance of recurrence in amblyopia. How frequently do you review these patients? Is it age dependent or dependent on the amblyopic factor?
Look, it's a good question because I don't know that I have a strict rule. I think it depends on how often I've been seeing them originally. I can recall a case of a little tot who's about 3, and I was seeing her every 3 months during her amblyopia treatment. So I've continued to see her every 3 months until we get that stabilisation of the vision, and then I'll probably drop it back to 6 months.
Okay, thank you, Linda. There's another good question there. How do you decide what you're going to prescribe for infants or young children?
Once again, it depends on whether there is a strabismus there or not. If there's no strabismus, then you're going to go for pretty much their dry retinoscopy because we're trying to provide good acuity. However, if there's a strabismus and it's an esotropia, we want to give enough plus to actually straighten the eye up. So I'll probably go for more the wet ret result in that case.
Great, that's a good answer, Linda. And there's another good question for us. Do you use anything to aid binocular fusion and stereopsis when you're treating amblyopia? So
e.g. opaque patching. What do you think that next word is? Blurring the good eye. Look, when I was preparing this, I actually looked at a paper that was looking at opaque patching, and the results aren't quite as good as atropine penalisation or total occlusion patching, But if it helps the patient cope better and the other options aren't working, then it's definitely something that you could do as part of your approach. Yeah, certainly wouldn't say it was something I would not do.
So we have another question. Is there a rule of thumb used to calculate the hours of occlusion based on age?
I generally start with 4 hours a day for children under 7. If they're over 7, I'm going to try and get them 6 to 8 hours. If the amblyopia is moderate, if it's very mild, then it's going to be slightly less than that. And if it's very severe, it's going to be a bit more than that. So about 4 hours is my starting point for moderate cases.
Great, Linda. And how often would you consider doing a cycloplegic refraction in your follow-ups?
I must admit, I generally only do cyclos at the start because I'm interested in what's there, but I'm not so worried about doing a cyclo at follow-ups. I'm really then trying to see how much plus I can push to maintain good vision but still keep the eyes straight.
So we've had a few questions about the percentage of atropine that we're using in amblyopia treatment. Would you like to confirm that for the audience?
It's 1% atropine.
Good. And we're just scrolling through. We've got a lot of questions coming up from you guys, so thank you for all the interaction that's going on. So we've got another question here from Zara. If you found that there was less plus gave better vision but did not control the turn, and more plus caused blur when a child is older, which would you choose to prescribe? That's a quite complicated question, Zara, so I'm glad you've asked us that.
So she's gone, for example, right eye +2 giving 675, and the left eye, if we gave them +3, they'd get 6.9, but still a left esotropia, or +4 giving 15, but only a phoria or no turn. Zara, I'd give the +4. We definitely need to control that turn. And in your example here, their +2 is still fine. It's still giving 675 in the right eye. So they're actually not going to notice that +4 gives slightly worse vision. What's going to happen is that because the eye is straight now, that vision will quickly improve, especially with patching.
Great. Thanks, everyone, for all these questions. And thank you again, Linda, for your presentation and time tonight. It was great having you on board. We've got our next presenter coming up now, and she's from our very own alumni, so we're very excited to have her here with us today. We've got Hayley Birch. So Hayley graduated from the 2015 cohort and is now working part-time as an optometrist and also part-time here at Deakin University as a clinical skills tutor.
Hi everyone, hope you're enjoying the webinar so far. So tonight I'll be delving into a bit of paediatric optometry, so myopia, which is a hot topic at the moment. Just to give you a bit of background as to why this is such an important area for us. A study in 2010 found that myopia currently affects 1.9 billion people worldwide. So that's about 28% of the world's population, but projected that by 2050, myopia will be affecting almost 5 billion people. So that's about half the world's population. So they're pretty significant figures when we think about the pathology that can come along with myopia. So I'll be talking you through an Ortho K case study that I've had at my work. We've been fortunate enough to have most of the evidence-based myopia control options available to us, and after recently purchasing a topographer, we're able to do Ortho K as well. So how do I get the next one? There. Oh, beautiful. So our patient today is a 12-year-old Caucasian male. He's been seen in our practice for the past 6 years, and currently he's about a minus 3.25 in both sides, with not much still. The next slide I'll show you is a table of his progression by years so far. But before we delve into that, I just thought we'd go over the sort of risk factors that we need to consider in our young progressing myopes. So the first one being younger age of onset, so anyone 9 years old or less is at a higher risk. Parental myopia, so one parent will increase your risk by about 3 times and 2 parents 6 times risk. Other things that we know are common are East Asian descent, where 80 to 90% of the population are myopic, any binocular vision dysfunction, particularly esophoria and accommodative lag. And then there's also a consideration for time spent outdoors versus time spent doing near work. So outdoor time less than 1.5 hours a day or near work greater than 2.5 hours a day can increase the risk. The mechanism behind that is a little bit interesting. So rather than it being that being outdoors is protective, it's not the activity level, it's rather associated with higher light levels, the lux of natural light, smaller pupils, relaxed accommodation, and less dioptric variation, which may be involved. So I've just popped up the table there of his prescription year by year. So as you can see, back at age 7 was when we first found him with mild myopia, and then things just moved quite slowly, only changing by 0.75 in the next 4 years. And then in May of last year, huge jump. So we had an 0.75 change in about 6 months, and then again another 0.75 change 6 months after that. So in May 2018, we started talking about myopia control as an option for this patient, but his parents opted to wait another 6 months and see what happens, and look what happened. So fast progression is generally defined as a change of 0.75 or more per year. So as you can see there, we've got about a 1.5 diopter change in a year. So he's going pretty quickly along there. So we talked about some good myopia control options in November for this patient. So I've put 4 up there. Others we've excluded just based on that they weren't suitable for this patient because of his presentation. He only had the young age of onset and 1 parent with myopia, but his BV was totally normal, and he's a reasonably active kid. He has a lot of time outdoors and he's not a big reader either, so that was pretty good. So we gave him Orthokeratology as an option, low-dose Atropine, multifocal soft contacts. He was already an existing spherical contact lens wearer, or they can do nothing again and wait another 6 months and see what happens. So out of those options, I've just touched here a little bit on the efficacy of each of those, and this is just pulling some figures from a meta-analysis and some numbers also from the lovely Kate Gifford's papers she's put out. So Ortho K and Atropine seem to be fairly similar. There is a huge range of variance from study to study about how effective each of these treatments are for myopia. Multifocal soft contacts a little bit less, and doing nothing obviously doesn't help us very much to control our myopia progression. Other things that we think about are, of course, progressive addition lenses, so multifocals, executive bifocals, and peripheral defocus specs, so myovision. So we opted not to do any of those 3 options for this patient. PALS, because he doesn't have esophoria or accommodative lag, we don't generally fit executive bifocals, and a 12-year-old really didn't want to wear it because of cosmesis, and we don't have access, unfortunately, to the peripheral defocus spectacles. So the patient actually chose Orthokeratology. He loved the idea of being glasses free during the day. As I said before, he was a big soccer fan, so he thought it would be amazing. He currently played without glasses on, and remembering there's a minus 3.25, so he was hoping to play a little bit better with the lenses as well. So before we went ahead and agreed that he'd be a suitable candidate for Ortho K, we had some primary criteria that he had to meet. So I've just listed on here 2 sort of areas of consideration, so to actually fit Ortho K, and then other things that may be important. So myopia between 1 to 5 diopters is ideal. You can fit higher than that, but it becomes a little bit more complicated. So certainly if you're new to Ortho K, I wouldn't suggest you do that straight off the bat. Corneal curvature, so we don't want the eyes to be too flat because there's less cornea to flatten down and reshape in the middle. HVID about 11 millimeters, which is about average anyway. Most people will have a HVID of 11 mil. Corneal eccentricity, which relates to how the apex of the cornea flattens or steepens all the way down to the periphery, and that's a value you get off a corneal topographer as an E value. So the higher it is, the more change there is from the apex out to the peripheral cornea. Against the rule of astigmatism, so that's our at 90 degrees, less than 0.75 diopter sil, with the rule 150, and of course pupil diameter comes into play as well. So if they've got bigger pupils, it's more likely that where the flattening of the cornea is happening may cause them a little bit of glare or halos, especially at night time. And then other things worth thinking about are the age of the patient. So doesn't necessarily stop us from doing it if the patient is younger. I know that there's been some quite young 7, 8-year-olds who have been successfully fit. We actually tried to fit a girl in her 20s in practice and she just couldn't wear the lenses at all. So she unfortunately didn't go ahead with Ortho K. So maturity is a big thing too. And this 12-year-old was very mature for his age. He was excellent, great competency already with his soft lenses and good compliance in cleaning. So what do you need to do Ortho K in your practice? I've put right up the top there that a corneal topographer is essential. In my opinion, I wouldn't fit without it. You can, of course, fit empirically. This may be a little bit more difficult. Whether a keratometer might be a suitable option, but remembering that it only gives us that central 3 millimetres, whereas a topographer gives you about 8 to 10 millimetres of cornea. You've got more accurate follow-up, and you can do a few different graphs on the topographer showing you how much refractive change there has been, helps you look at the centration as well. So other things that we all have access to already is a baseline refraction. That's fairly straightforward. Would a cycloplegic refraction be arguably better? Yeah, possibly. We've had a couple of Ortho K patients who we've given the lenses to, and they've actually come up being a little bit overcorrected in their glasses, and we've had to reduce the power of the Ortho K. We've all got slit lamps, so we're able to do those pre-corneal checks. We can all measure HVID quite easily, and we've got awesome people at the gels, so ACL and GelFlex, who can really help us out. So for this patient, we did the fitting of the lenses and then a review after night 1, week 1, month 1, and 3 months later as well. So this was his topography. So this was about 2 weeks in. So as you can see there, just on the top left-hand side is before we'd done any Ortho K, so that was sort of mid-November. And then this is 2 weeks later down the bottom, just about 3 weeks, or no, it's just the first week of December there. And so you can see that central flattening of the cornea. It does look on that graph like it's slightly decentered temporally. However, where those spots are is just where the topographer's filled in, where it couldn't read the placido rings very well. And if you look at the colours down the side, we can see we've had about a refractive change of 3.5 diopters. And again, just remind you that here's about a 3.25 to start with. With Ortho K, we're aiming for them to be about plano to plus 050 in the morning. So we were pretty happy with that. Alrighty. And so here are just a couple of things that I thought were quite interesting on my journey of fitting Ortho K. So for some reason, I didn't realise that when you initially inserted the Ortho K lenses that they would be able to see. I thought they would have to work. You'd have to wait a few nights before that cornea has been reshaped before you get good vision. However, the lenses actually have prescription built in, so your patient should be 6/6 or better, and this will give you an idea of what you could expect vision-wise once Ortho K has finally set in. And the other thing that was interesting too is that the corneal changes. So it was first theorised that epithelial cells actually migrated to the peripheral cornea, but new studies have shown that it could be a change in the cytoplasm density. So that's the sort of liquid that fills up our cells, so that being less dense in the centre and more dense peripherally. So that was interesting too. So to just let you know how the patient is going, after night 1 he was about 2 diopters less myopic, so only about a minus 1.25 now. So we just gave him some daily lenses to get him all the way through the day. And then after, as I said, about 2 weeks later, he was about 6, 4.8 unaided, so really, really good vision with only a slight hyperopic refraction in the morning, and he's maintained that since December. And so far, pleased to report there's been no progression. So it is certainly early days for him, but going off his rate of progressing 1.5 diopters in 16 months, we would expect about a 3.75 diopter progression in the 4 months since he was fitted. And there has been no change, so that's maybe all the evidence we need so far. And that's everything. Thank you, guys.
And thank you, Hayley. It's been great to have you along tonight and a great addition to our paediatric webinar tonight. So again, it's time to ask Hayley some questions. If you have any burning questions about Ortho K, we'd love to hear from you. To get started, Hayley, what advice would you give one of the alumni members who's looking to start getting into Ortho K? So
I think if it's your own practice, obviously the best advice would be getting a corneal topographer if you don't have one already. If you're working with other optometrists, perhaps speaking with your boss to see if that is an option as well. That would be fantastic. But it's definitely a good thing that we should be giving our patients the opportunity to have. It works really well. There's a lot of evidence base behind it. So I think just diving right in, picking some patients that fit that criteria first would be really useful. So don't do the most complicated patient first. Pick someone who's a -1 to a -5 and has all those other criteria that we like, and go from there.
So when you first started, did you have a patient in mind and offer it to them as an option?
Pretty much. So we had that sort of criteria written down in the back of our mind, and then as we saw patients pop up and they were progressing myopes and they fit that, we gave them the option there. So that's pretty much how it started, and now we've fitted a few more in the clinic that are high myopes and or just, they just want the refractive correction without being in glasses or being in soft contacts. They just want to be, spectacle free during the day.
And here's the big question, I think. How much does Ortho K cost? And you can talk about the range that's out there.
Yeah, so look, at my practice, it's $1,150, and that covers their lenses and all their follow-up treatments as well. So I think that's a little bit less than other clinics. I've seen them up to $2,000 at some practices in Melbourne. In terms of cost price, the lenses will cost you about $300 a lens. So you've certainly got to think about that when you're starting out as well. So you've got to cover that baseline cost and the chair time going on from there.
That's great, Hayley. Really good. So we've got a question here about what age range do you think is most studied? And I suppose that's referring to Ortho K in terms of controlling myopia progression.
Yeah. So in terms of most suited, if you're talking about myopia progression, you want to get them while they're young and progressing. It's interesting though, nowadays we're still seeing people with myopia progression into their 20s as well. And although there's not a lot of research to support Ortho K slowing down progression at that age range, it doesn't hurt to give your patients the option and to try. I am fitting currently a 24-year-old who is progressing about 0.75 every 6 months as well, and she's doing really, really good.
So we also had a question about whether you take ROP before you fit Ortho K and the effects that might have on intraocular pressure.
Yeah, certainly. So you absolutely want to check IOP before you start. It would be good to measure, your corneal thickness once Ortho K started. Obviously, there is that thinning of the epithelium. It doesn't change the thickness as much as you would expect. So it's only about 1 mil overall, depending on the level of myopia. Obviously, the higher levels, it'll be more of a corneal flattening there too. But absolutely check your IOPs before you start.
Mm-hmm. And now we've had that long discussion about atropine for myopia control. Is Ortho K now your preferred method for controlling myopia when you talk to patients?
At the moment it is, and only because anecdotally we've had quite a few patients who we've had on atropine for a long time, so 6 months to a year, and they're still progressing at the same rate. So in which case we've opted to give them the option of doing Ortho K as well.
Okay, thank you so much, Hayley, again for joining us. That was an excellent addition, like I said, to our presentation, and we look forward to seeing you at other Deakin alumni events in the future.
Thank you very much, Amanda.
You're welcome.
Thanks, everyone.
So next up we have joining us Daniel Farrugia. Farrugia. Okay. Don't get that one wrong. So Daniel's worked in private practice in Werribee for the last 14 years in Victoria. He supervises students from the Deakin University on their clinical residency placement, and he occasionally speaks to community groups and students and has a lot of experience managing paediatric patients. He's also hoping to get around finishing his ACPRO fellowship sometime soon. So welcome, Daniel, and I'll hand it over to you.
Thank you. So I'm actually presenting 3 cases, so I'm going to burn through these as quickly as I can. So I frequently get people referred to me as being the second opinion, and I thought that would be an interesting take on things. Now, some of you will know who I am, that I'm involved with the Deakin course in some degree. So I've put an obligatory photo of my family. There I am with my wife. Don't be fooled by how adorable my children are. My eldest son is actually punching that plush koala in that photo. But there they all are, so you can visualise me. I'm the one on the very left. So let's look at PP, who's a 13-year-old female who was brought in to see us. So she'd been seen by another optometrist who'd actually referred to us to possibly do some VT for this patient. So vision wasn't great. She was having difficulty refocusing, going from distance to near, sometimes getting double vision. And the referring optometrist thought the best way to deal with that would be to do some VT. Now, there are my findings. Nothing particularly exciting there. Oh, have I gone backwards? No, I have to. So when we did some of the BV tests there, that's what we were getting on blur function, reasonably steep ACA ratio there. Maybe I want to draw attention to, we had a very good PRC, MEM was a little bit tight. I probably should talk a little bit about what a blur function is, because my experience is that not a lot of the students we have through actually know what one is. So I'm quickly going to talk about blur function. I'm not going to read everything out there. You can look at the slides later. But it's essentially a technique where you overplus the person and then you wind it down until they get to 6.6. And then you do a balance between the two eyes at that point when you get to 6.6. You can plot that on a graph, and it should look like that when you plot the lens power against the minimum angle of resolution, which is not the logMAR, it's the before it's had that conversion. And it should be a straight line. When it's not a straight line, there's something very wrong with what the patient's eyes are doing. So, looking at that patient, I'm going to try and keep this as interactive as I can. These are possible ways we could treat it. Is it near point stress and you treat with a low plus in a single vision near form? Is it near point stress and you treat it with a low plus in a multifocal with some Yoked prism? Or would you do the VT that the referring optom had suggested? Or what you're seeing is actually early myopia and you should commence on myopia control options? Or maybe it's E, what are you talking about with near point stress? I'm going to take a little tangent again for this. So essentially near point stress theory is a way of thinking about the visual system as basically it's under stress. You get changes that happen to try and allow the individual to cope with the task that they're having to do. It puts undue strain and concentration that they have to exert. But then you get these long-term adaptations that happen over weeks and months to try and maintain function, and you eventually get fatigue and breakdown, which manifests as double vision and sore eyes, and in some cases avoidance entirely. So I could do a whole lecture on that, but I'm just going to leave it with this little table. You can basically classify it as situations where you've got the patient being better at converging, so they use that to try and drive the system, and you've got a lag and accommodation, or vice versa, where they're better at accommodating, so they accommodate to try and drag the convergence in. So going back to our question, how would you treat this patient? Well, I went with C. No, I didn't. I didn't go with C. I didn't go with VT at all. Okay. I actually went with B. Oh, that's my bad. Sorry about that, everyone. So I put them into a multifocal with some Yoked prism, and they actually responded pretty well to that. They were finding it easy to refocus. The patient really noticed when they didn't have their glasses, they noticed the difference. And their unaided acuity was actually a little better. So there are the patient's BV results. They had a little bit less ESO there. Now, these are all results when they were unaided. So we're comparing, the goal is that you're comparing like for like. We were getting a better MEM unaided. Once again, it was starting to look a little bit more natural there. And I didn't do any VT for that patient at all. Someone may ask why we do Yoked prism. The theory behind Yoked prism is that by shifting the image upwards, things that are close up look like they're actually a little bit further away, and so it reduces the stimulus for accommodation and convergence. And so it generally advocated as a way to treat an ESO deviation at near. Now, in terms of the data on that, there isn't a lot that I can point to. Steve Leslie does a really nice summary about everything to do with Yoked prism on the ACPO website, so if you've got access to that, you can check it out. If you don't, you can email me after the presentation and I'll be happy to send that out to you. But there isn't a lot of good evidence that I can point to and say, yes, this is why it's done, other than you shouldn't go too much and you shouldn't go a little, which is why I tend to do 2 base down yoked. Okay, so the take-home message from this case I thought was, the person you're referring to won't necessarily do the thing you're asking for, and that's okay. Because sometimes the reason you're referring them is because you're not actually 100% sure what you should be doing. So I have another case report, which I'm actually just not going to do because we don't have time for it, and it's very similar to that first case. It's just a different flavour. This one is a bit more interesting. Now, you'll notice this isn't technically a child, but it was interesting enough, and it was kind of dealing with similar issues that I thought I'd include it. So this patient presented to me. They were getting blur intermittently, far away, close up. It had been going on for a while. They were getting sore eyes and burning eyes. Sometimes they got a headache, sometimes behind their ears. And they'd been seen by another optometrist who was going to refer them on to an ophthalmologist. And with those sorts of acuities, you can understand why, because there's nothing to see in this patient. They had unremarkable internals, maybe a little bit of SPK, but certainly nothing to reduce the vision to 6/120. They had, on cover test at near, they had a left esotropia, but excursions were normal. The ret was really, really unstable. And I couldn't actually obtain a result. Now, as a new graduate, you might feel like that, oh, maybe I'm just not very good with this ret, and that's why I can't do it. I never feel like that. If I can't get a ret result, there's no ret result to be gotten. So I was pretty confident that we were just getting some really whack numbers because it seemed to be swinging around everywhere. So what would you do? Now, looking down that list there, you might laugh at B, but this case was presented as a clinical conundrum by one of my students to a Deakin cohort, and the supervisor actually went, I don't know what I do, maybe I just give him a placebo. So I hope he was joking. I'm not sure, but that may be something that someone considers. I can't really do F if I'm going to refer for another optometrist's opinion. I'd probably go to an ophthalmologist at that stage, particularly with paediatric stuff. So I did D. So this is all basically everything that I've circled. It's going to be the one above because it hasn't transferred across. At least I can work out which one it is. So I did D, not E. I actually dilated her with cyclo. And cycloplegia was magical. Where's the slide? Oh, no, there it is. So I got her back on another visit, and we found that with cyclo, and her vision improved to 624 with my cycloplegic ret. Subjectively, we got it to 6.9 from 6 on 120. So clearly there's something really crazy going on with this young woman's accommodation when she's not under cyclo. So this is what I gave her. I gave her this really Mickey Mouse script with a really Mickey Mouse ad, a bit of Yoked prism, put it in a multifocal form and said, okay, I want you to wear this full time. I don't often get kids to wear their glasses full time, but this was such a bizarre case I thought I needed to. And we said we'd see her in a month. And I saw her in a month. Now she's saying that the vision still goes blurry occasionally, not as often, but when it does go blurry, it goes blurry for longer. Wasn't getting any headaches or sore eyes anymore. And the unaided acuity had improved to 660 in that left eye, which you might not be thrilled about, but I thought it was a pretty big improvement. She was esophoric in the distance. Those of you who are paying attention will note that I said esotropic at near, so those results don't necessarily contradict each other in terms of being an improvement. And now we're actually able to start getting some numbers with our ret. Left eye was still really unstable, but at least we could get some measurements now. At 3 months, the vision with glasses had improved to 6.9. At 5 months, she was 6.7. So this is one of those cases that we were really happy with. This young lady actually was in the practice, I think, only a couple of weeks ago. She's doing fine, no regression. Unfortunately, at one of the visits to me, her dad found out that she dropped out of her correspondence course at uni. But otherwise, she's doing really well. She did have to have a very serious discussion with her dad after that. So the take-home message that I've got from this is that adults can get BV issues as well. Children with BV issues that aren't treated become adults with more complicated BV issues. They can be more entrenched, and because they're entrenched, they take longer to resolve. The longer it takes for them to get where they are, the longer it's going to take them to recover. So, one more, very much a child case. So this is a very recent one for us. EL was brought into us after being seen by multiple other optometrists with diagnoses including myopia, astigmatism and amblyopia. She'd been prescribed glasses, but she didn't wear them. This was her unaided acuity. Internals were pretty normal. Everything about her BV results was pretty normal. No movement on cover test. But then we had, with RET, we had a little bit of minus in the dry RET. And subjectively, a little bit of minus and SIL gave us an improvement, but not much. Certainly not an amount that you'd consider amblyogenic. So what I want to point out, though, is that when we were doing RET, we noticed a central opacity in the red reflex. And so I don't often get kids on the slit lamp. I'm not ashamed to say that. I do when I'm concerned, and this was one of those times. So when we did that, we saw this. So we saw this area of little opacities in the cornea centrally with, they were kind of bluish in appearance. It was really hard to get a look at them because initially she blinked a lot while we were having her on the slit lamp, probably because I was shining a light into that opacity. And I initially thought it was a posterior cataract, something congenital. But no, it was staining with fluorescein. And so I went, okay, maybe we'll treat this as a dry eye. And my take-home message from this whole case is hashtag dustoffyourret. This was a hashtag that Kate Gifford championed at the SRC a year ago, and it is such an important piece of equipment. I cannot stress enough how important it is to do RET. You find out things that you're not going to find with an autorefractor or having just doing things subjectively. So I haven't done a multiple choice for this one because it was so wacky. I'm still not, frankly, sure exactly what we're dealing with, but my tentative diagnosis is that it was a unilateral Thankyou keratitis because I thought it looked a little bit like that. So we put her on FML 4 times a day, saw her again in a week. In a week's time, maybe the staining looked worse. Continued with FML, saw her at 2 weeks. The staining was over a larger area but less concentrated in the middle. We saw her at 3 weeks, and the staining was small again. It was still less dense. So we thought, great, we've kicked some goals here, but it's we were thinking maybe we're getting a bit of a toxic response with the FML. So and the vision hadn't really improved. So we switched to Genteel, which is a fairly gentle lubricating gel 3 times a day, and we saw it a month, and the staining looked better, but the vision was still 6/12. It wasn't improving. And when I have these situations, I start getting suspicious. So I'm going to do a topography map on this patient, and we saw this, and that is a crazy looking cornea there, and you can kind of understand why she's not getting 6/12 and why we were getting the SIL. So when I saw that, I went, right, let's put an RGP on this patient and see what effect it has, not for the long term, just diagnostically. And when we did that, we were able to improve the vision to 6/6. So at this point, I'm fist pumping the air because I thought, I've sorted out what's going on. We know that your child doesn't have amblyopia. So, we're happy with this. Let's just continue with the lubricants and we'll see you in 3 weeks. So we saw her at what was now the 2-month mark. Vision still wasn't great. Dryness we still had this staining centrally. And at this point, so meanwhile, the parents have been coming in with their other daughter, who's a doctor. I didn't mention that at the start. This is something that's come in recently. And they've decided, look, we want to see an ophthalmologist for a second opinion, just for our own peace of mind. We understand that things are okay. But having said that, they still said, we want to come and see you again in 3 weeks' time to get you to do the follow-up. But they just wanted this extra opinion, and I completely respect that. So when she saw the ophthalmologist really didn't have anything to add. She did do a corneal swab to rule out infective keratitis, which was negative. She was on the fence about the Thankyous, but acknowledged that it could look different at the initial presentation and said, just keep doing what you're doing, go and see Daniel. So the take-home message from this one really is dust off your ret, and children can have pathology as well. Now, I saw this patient yesterday, and she hadn't really gotten much better, but at that visit, the sister said, could it be an allergy? And I said, are you getting any itching? No, you're not getting any itching, probably not an allergy. The opthal had mentioned maybe it was an allergy. Then after I had a look at her inferior lid and inverted, I went, oh, they could be some mild papillae. Let's try treating that. Then the sister, who's a doctor, volunteers. I had the same thing as a child, vision dropped in one eye, didn't actually have anything done, didn't have it treated properly until I started getting the itching, and then we treated it as hay fever and it got better. And all I could think was, why didn't you volunteer this to me when we started? This could have been a much shorter process. Anyway, so yeah, children can have pathology too. Make sure you use your ret. It does tell you a lot more than just giving you a refraction and a number. Sometimes you can see stuff that you would otherwise miss. So thank you very much. There's my email address if you want to get copies of slides from me. And I think we're going to take some questions now.
Yeah, great. Thanks so much for that presentation, Daniel. It was very interesting indeed. So if you have any questions for Daniel, we'd love to hear from you. We've got a question first up for Daniel. You've mentioned that for near-point stress, you prescribe vision therapy. Can you describe the regime that you would use for this type of treatment?
I think I try and avoid VT whenever I can because I'm a time-poor parent, and I try and do the thing that's going to get the best results because it requires the least work from the parent. But when I do VT, it is always because the patient has convergence insufficiency. They have an exotype deviation because that's been shown to respond really well to VT. I think if you're trying to do stuff for accommodation or for an ESO deviation, I think you're going to be struggling to make that work. And oddly enough, that first case that I was referring to, the patient did have an ESO deviation, so there really was no indicator for VT for him or her, I can't remember anymore. But we do stuff with Brock string, making them more aware of giving them an awareness of diplopia. But yeah, Brock string is probably your bread and butter for doing convergence training.
Okay, great. And how do you decide exactly how much plus that you give a patient when prescribing a near eye?
Okay. I get asked this by students all the time. I generally would err towards plus 0.7. That's my kind of baseline measurement. I'm going to give plus 0.75 for a child. If they have a tendency to over-accommodate, you might want to ease back on that a bit. There have been a few patients that I've needed to go a bit more than that. I'd say take your ret out, do a near ret, and try your proposed ad in a trial frame and see what that does to what the reflex looks like, how much, whether it changes their position of focusing, and use that to guide what you would go with.
That's great. Thanks so much, Daniel. And that's probably all we have time for tonight. So thank you very much for your presentation today. We really enjoyed it. And everyone, we'll just tidy up with some housekeeping now. So what we do have to bring to you is the next alumni event, which will be happening on the 14th of June. So that will be our annual reunion, and we'd love to see you there. So stop by if you're in town. It's going to be at Blackman's Brewery this year again because we had such a fantastic time last year. So pop that in your calendar. And there's also an opportunity for people who graduated in 2015 and 2016 to get involved in our clinical residency program. So to become a supervisor, if you're interested, send David Hammond or myself an email just to register your interest or see what else is involved. It has changed a bit since you guys would have gone through the program, but we'd love to hear from you, even if it's just to flag your interest. So now the benefits of being involved is that you do get access to the Deakin University website, so the library, all its resources, the optometry and ophthalmology journals. You get recognition amongst your peers that you're going to be a supervisor. And this year we're also offering a mentor training program. So that can be related to staff at the optometry practice as well as students that you're involved in. So a good thing to pop down in your CV. And of course that satisfaction and recognition that you're involved in the course again. So we'd love to hear from you. We're all about alumni supporting alumni here at the Alumni Committee. So let us know your ideas for the next webinar. We're going to be sending out a SurveyMonkey feedback survey to you guys, and we'd love to hear what you'd like to get shown at the next webinar. One thing I heard the other day was diplopia as a topic, which could be fairly interesting. So if there's anything else that scratches your brain, let us know. Also, we'd love to hear from you if you're doing some interesting research or you're involved in a project that other alumni members might benefit from hearing from, because we want this to be a platform for you to get involved and get some recognition in what you're doing too. So finally, we come to Dashboard. So this is what we'll be using for your CPD activity for this webinar. So you'll get 2 points for the CPD activity, but completing this quiz means that you'll get that extra point, so a total of 3 points. Like I said, you will have received an email from Dashboard at the end of last week. If you've lost that, check your trash file or your junk mail file. And if you're totally at a loss, you can contact one of us here, Jack, Lucy, Ash, or myself, and we can reset your password for you. But remember, we'll be using this moving forward for all our optometry alumni events and even any CPD events at Deakin University. So if you are registering in future events, please use the same email address, and that means you won't have to create a new password every time you sign up, and we can use the same one. So thank you again, everyone, for joining us. It was fantastic to have you all here, and we're looking forward to next time. Until then.